All right, and last but not least, we're going to invite Dr. Jason Perfetto to talk about his work. I'm going to make him in the spotlight there. Hi, Jason, you're in the spotlight now, so thank you.
Thank you, and thank you to all my fellow speakers. I think this has actually been a really informative session thus far, and hopefully I can get through a few minutes of speaking without my son coming to bother me for a drink or for a snack, so I think this should work out. I don't have a presentation. I just want to make a few points. So I have three things that I want to learn or to share. The first is around lessons learned. So one of the things that we've done at the medical school is we've been teaching virtual clinical skills for a little while now, and we've come across a lot of different learning lessons. And one of them is that MSK, neurology are very difficult to teach via a virtual setting. Sorry, one second. My dog's barking. Sorry about that. The other thing is that derm, ophthalmology, and ENT also have a very different feel to how they're actually being delivered as well. Whereas the three main examinations that we teach at the beginning of medical school, the cardiac, the abdominal, and the respiratory exam, actually have a much better way that you can teach in a virtual setting, especially in a much more consistent way. And I can elaborate on that. So there's been some interesting lessons learned. The second point, which is interesting to hear about OSCE experience, is that we did deliver an OSCE. It was really cool to see like both the asynchronous and synchronous delivery of the OSCE. We delivered an OSCE with 10 stations, all virtual for over 200 students. And we actually later found out that apparently is perhaps the largest virtual OSCE that was ever delivered in like the history of North America. It was very, very intricate. There's a lot of moving parts. We did it all in a 6-hour period with a software called Simulation IQ. So just getting into like synchronous and asynchronous delivery of the OSCE in the virtual setting was a very interesting thing. And the last point I want to say, which, you know, perhaps is becoming one of the more interesting points, is that I think what's happened, especially in the medical world for medical education, clinical skills, virtual, is that it was a substitute for the fact that we were not able to deliver clinical skills live and in person. But what's slowly starting to shift is that many people are accepting now that clinical skills virtually may transfer into clinical practice virtually. And there's many docs, and Ontario MD is doing a lot of work on this. And I had an opportunity to collaborate with a few people from Ontario MD that what we're doing now may actually be training for the future, so that our future physicians, our graduating doctors, our graduating clinicians across all the fields will get used to actually, they'll be trained and prepared to deliver clinical skills, to deliver their area of medicine or clinical practice in a virtual capacity. So that's interesting too, just from a pedagogical and practical sense, how that's starting to shift. I have a lot that I would like to say about clinical skills in the OSCE. I think there's been a lot of great points. I think if we go to a question and answer, it might be a little bit easier to address it like that, but I'll stop there and be brief.
All right. Thank you very much, Jason. I'm going to put us back on to kind of like the gallery view. And so I'm going to invite all the speakers to turn on their videos now. And I'm going to ask everyone to maybe if you have questions, you can type them and put them in the chat, or I can ask them on your behalf, or it's a small enough group. If you're feeling comfortable, please feel free to just turn on your video and ask it yourself, or audio. So one question that I had was along the lines of what, actually Patsy's asked exactly that question. Why is neuro difficult to deliver in the virtual setting? And maybe I'll ask Jason first, because he kind of brought it up, but I foresee that others might have similar kind of impressions or have some suggestions on how to overcome things as well. Jason, over to you.
So here's sort of the basic rule of thumb that we discovered. Anything that requires the thorax is a lot easier to teach virtually in the medical world, and anything that requires the extremities and the head and neck are much more difficult to teach. So what we actually did in the OSCE is we used a pillow. I know this sounds a little bit silly, and there's people right across North America that were both admiring and also teasing us about what we did. But we actually used a pillow for the OSCE, for the abdominal respiratory and cardiac exam. And if you can imagine an actual pillow, if you set it up on a chair, it's actually very easy to mimic a thorax, and it's actually very easy to mimic an abdomen. The problem with the neuro exam, there's a lot of small, nuanced, detailed little things that you have to do. And unless you have a standardized patient with you or another human being with you, it was very difficult to, one, teach it, two, observe it, and three, be able to practice it and get feedback on it at the same time. Similarly with the MSK. Not to mention there was a little bit of, I don't want to say resistance, but a bit of concern from the actual teachers that they really, really felt that the virtual environment was not ideal to deliver it. So as a result, those things in particular became a little bit challenging.
I'm going to maybe ask, because I feel like Jasdeep and Justine might have some insights, because that's a lot of what they do is MSK and head and neck kind of stuff. So maybe I'll kick it to you two to kind of highlight some suggestions, and maybe some of the things that Justine has highlighted might be the solution.
When we were in the breakout groups, I was chatting with Carl, and Carl actually had a possible solution that might work here. As he was talking about getting the students to wear the head cam, and so that he can see through the students' eyes, so to speak, to give you a bit more of an up close image of what you're seeing. And that is what we're finding really challenging, is because dealing with the head and neck and the brain is not easy, and we're our big task for that comes up more in January through March. We're sort of really hoping we're back in person for then, because I'm not looking forward to having to figure out how to do it. But I also didn't think we'd be able to figure out how to examine the oral cavity in any detail, and we figured that out. So I think sometimes, necessity is the mother of invention, and if you've got the students, you have to get them to a certain competency level, you're going to figure something out. Jazz, I don't know if because you've done a lot this summer with all these different skills, but some of them you brought into the building for.
Yeah, I was just going to say thanks, Justine, having to deal with a lot of MSK, and I agree it's challenging when you get to neuro and the extremities. I think we had to make a decision, because we did do a boot camp style, recognizing that there's just some skills that involve motor planning and technical skills that your students are going to need. You need that skill acquisition, and we backloaded those to the time that we were delivering in person. But we had to be considerate, like Justine said, and thoughtful and innovative in how we took 70% of the skills and front loaded them, so that they already had all of the background information, the clinical reasoning that went along with the MSK and neuro, so that when we brought them in person, it was really just the handling, the physical, the technical, the motor planning that they would be able to tie to the clinical reasoning.
Teresa, can I just add something real quick?
Yeah, go for it.
So the other interesting thing is that we found the opposite for dermatology. So to teach dermatology, and someone was mentioning the use of Kahoot. Kahoot's a very, very cool software that you can use to teach in a virtual setting, or like a more interactive online setting. To teach dermatology with using a lot of pictures, Kahoot, giving students, everyone, an opportunity to describe a rash and go from picture to picture to picture we would actually argue it was more effective than what we were doing in person. Whereas things like MSK and neuro, we had some challenges, and it's interesting to hear the feedback from others, but stuff like dermatology it was more advantageous. Very
cool. Are there any other questions right now?
One thing in my breakout with Helen McDonald from the midwifery program, I think she started to think creatively. I wonder if I can put you on the spot, Helen, to reflect a little bit on what you thought might be useful for the midwifery program after our discussions.
I'm not sure that I was thinking creatively. I was still stuck on Dorothy's ice cream choice. We have been, we are going to be sending out materials to students. One of the faculty that we work with in fairly close contact at Ryerson University has had for years an interest in what she calls the kitchen simulation. So we will focus, I think, quite extensively on using simple household objects to teach very, very basic skills. So, you want to teach things like I don't know, cervical dilatation, then you collect everything that's a circular object in your house and put your fingers in it, right? And figure out what the dilatation is. We will be sending them, equipment along with videos of things like urinary catheterizations. So we'll be sending them little sponge models with balloons in them and with catheters so that they can actually catheterize something. So those sorts of very, very basic simulations is what we're probably going to focus on. We also will have the opportunity to bring students in for what Justine calls the boot camp for a couple of days or 3 days, I think, during the course of the term. And we'll front end load all that with, like all the didactic stuff, all the theoretical material will come in advance of that. Is that what you were thinking, Dorothy? Yeah. Okay.
Yeah, that's very cool. Kind of try to help people think creatively about the objects around, right? I assume even with like things like Play-Doh or other things like that, you might be able to actually model up a whole bunch of different things.
There's all sorts of things. I mean, you take an orange and carve fontanelles and sutures out of it and put it in a sock and hide it under a blanket, get your friend to rotate it so that you can, assess where the sutures are, those sorts of things. It actually is quite, it can be really quite entertaining. I did a session here at my house the other day. I actually had a torso and a doll, like a proper model. But I had some students on Zoom who then delivered babies through turtleneck sweaters, sweatshirts, right? So it's just a matter of, and obviously that is not ideal at all, but still it gets them, gives them some idea of where their hands go and how they use the hands and how they think about what they're doing. So I think it's useful, and we'll be able to consolidate that when they come in for their little boot campy thing. Thank you.
Okay. All right. Well, thank you very much for sharing with us on that. All right. So
can I jump in here? This is Ohud. I'm with the PA
Ohud.
program. I think we also have to start thinking about resource allocation as program directors and as kind of the people setting up these educational opportunities. So students are paying tuition and they're expecting to get good value for their money. And if we're not putting that money towards use of space or maybe use of the sim lab or access to those patient rooms, maybe we should be investing more in models, real life models, partnering up with industry. For example, in orthopedics, there are a lot of good models for a shoulder or a knee that would allow students to practice something like a special test for the knee, like an ACL, which was very difficult to do. So we just completed MSK with our PA students, all virtually. And I think the most challenging part was those MSK and neuro exams where you really do need to kind of have access to a limb or an extremity. So just something that, outside, I think we do have to think about the budget and resource allocation.
you just have to be very wise when you're selecting different things that you're going to be allocating resources to. But for sure, it's something that we should bear in mind, that the quality of the education when we're using substitutes is probably not perfect. And so it's something that we can then maybe invest more heavily when there are boot camps and making sure that those give people more of that hands-on feel with maybe more direct observation. So I think those are some of the things that I've seen people more heavily investing on in more kind of like intensive training. When you do have people, they're usually smaller groups because you have to do the social distancing. So that's definitely something to think about. All right, Dorothy, go ahead.
I wouldn't mind hearing a little bit more from Jason about lessons learned in doing 206 or whatever OSCEs online. Can you give us a little bit of your reflection on it? Because it sounds like quite a a major undertaking.
Thanks, Dorothy. The interesting thing now is that we're actually going through a very similar process for the interviews for medical school coming up, right? So with the medical school interviews, we normally interview over 550 applicants. And now we're starting to talk about the scalability of these different virtual tools that we may or may not use for a interactive virtual setting. And again, the MMI is going to be 10 stations too. So with the OSCE, where we really struggled was, we have over 200 students. We didn't want to compromise with the amount of stations. We had consulted our research scientists from Merit in terms of the psychometricians, the people that really knew and understood things like validity and reliability, and how that would relate to the amount of stations we have and how that would relate to the type of assessment we're doing. So I pushed to really try and include 10 stations for the entire thing. It worked well. What we ended up doing was 3 physical exam stations: cardiac, resp, abdo, 3 different stations, 3 communication/history stations, and then there was 4 what we called clinical decision-making stations. And one of the things, it was the most challenging thing is we didn't know where to start. So do you start with time? Like, do you want everything to be done within a given day? Do you start with a budget? Do you want to be everything to cost within a certain amount? Or do you start with an actual OSCE structure? Do you want a certain amount of stations, a certain amount of students to come through? And all of those things came into play. We arrived at a budget. We knew that we had over 200 students. We knew that we wanted 10 stations. And then the big thing is that we wanted to be able to complete this within a 9-hour window, because it really started to affect everything that we did with our human resources, our admin staff, and how it was going to run. Overall, it went very, very well. The number one problem we had was the turnaround time between stations. So like, all this glitchy stuff where you end a station and it takes a 10-second thing to load, and then it might not load right away, and then it loads. That was the number one problem we had. The 1 minute turnaround was the number one. There was no issue about performing physical exams on pillows. There was no issue about the communication with standardized patient. There was no issue about the content of the clinical decision-making cases. We did an MSK. We did a Neuro one. For the Neuro one, we had a picture of a lady that had Bell's palsy, and you had to talk about lower motor neuron versus upper motor neuron and the facial nerve palsy and what happens and that sort of thing. So we had an actual picture with the asymmetry. So at least there still was it was very heavily clinical skills oriented, and we were still able to touch on a lot of different things. And now, since we did that OSCE, a lot of other schools have been reaching out to us to sort of get a sense of our experience. It was very interesting. There was a lot to it. And the one last thing I'll share is that everything's video recorded. So every station, every encounter, every station, every physical exam is archived. So for remediation purposes, for anything that we have to go back to, we actually have it all recorded.
Jason, what platform did you use? Did you use to run the exam?
Simulation IQ. And just to give you a quick number, so our OSCEs generally cost $1,000 per OSCE, 3 OSCEs per year, 120,000 more or less. That's our budget. With Simulation IQ, there's all these licensing fees and this and that, but the total cost of Simulation IQ was significantly less than our live OSCEs, because we didn't have to pay as many standardized patients, and we didn't have to buy food. And go figure, the food ends up being one of the major costs that we actually have. And also the one other thing is that validity was protected, because our assessor pool was smaller, which means we didn't have to scramble and really put pressure on people to assess.
Those are some fascinating insights about the OSCE. So definitely very interesting. Now we have like the tale of 2 OSCEs basically from today's sessions with Justine's story and then Jason's story, so that's really awesome. Okay, so I think that's about all the time we have today. Thank you so much to all the speakers. You've done an amazing job as always. And we're really excited that you're able to join us to share your stories. I'm going to end the recording now, but if people want to hang about and ask some questions or turn their cameras on and join me in a round of applause, that'd be great. And I'm going to stop recording.